color of COVID-19 Maryland, confronting racial and ethnic disparities during a global pandemic. I'm going to be your host. I'm Dr. Stephen Thomas, Professor of Health Policy and Management at the University of Maryland, and I direct the Maryland Center for Health Equity. And here we are here in College Park, and I will be joined by Omar Neal, the former mayor of Tuskegee, Alabama, and the internet talk show host of You Got the Power. We're going to have a conversation today, and you're going to be hearing from a tremendous, wonderful lineup of speakers. And it includes a welcome from our Dean, Boris Lushniak, who is Dean and Professor of the University of Maryland School of Public Health, the Rear Admiral retired from the U.S. Public Health Service, and the former Deputy and Acting Surgeon General of the United States. We're so happy to have him with us. And of the lineup of a conversation tonight with legislators and scientists and voices from the community, Senator Charles Sydnor III. He represents the District 44 in Baltimore County. Senator Clarence K. Lamb, MD, a physician legislator representing District 12 in Baltimore County. Dr. Deidre Cruz, an associate professor in the School of Medicine at Johns Hopkins. We have Gabriel Acevero, representing District 39 in Montgomery County. We have the director of the Maryland State Office of Minority Health and Health Disparities, Dr. Noel Braithwaite, who also happens to be an alum of the University of Maryland School of Public Health. And we have Delegate Jocelyn Pena-Melnick, representing District 2 in Anne Arundel County and Prince George's County. Next. And our very own Dr. Sandra Quinn, Professor and Chair of Family Science, Director of the Maternal and Child Health Program, and Senior Associate Director of the Maryland Center for Health Equity here at the University of Maryland School of Public Health. And so let's set the table. Tonight is going to be about solutions, but we have to also acknowledge the problem. And what we did here was just pull in some of the data from the Maryland dashboard. And one of the things I want our speakers to do is to help make sense of these tables and numbers and break it down so people can really understand the challenge and the opportunity that we face. In the country as a whole, there are over 1 million people who have now been infected with COVID-19. The deaths are mounting, although there are plateaus in certain parts of the country. And on this dashboard, you'll be able to see exactly what's happening in the state of Maryland. One of the big news items from Maryland is that there will be testing of all of the in-care residents, nursing home residents and their staff. That's the big news today that the governor announced. Very important that these vulnerable populations are part of the testing protocols. And so again, this is being brought to you by the University of Maryland School of Public Health. And here's our first question for the audience, our Facebook audience. We want to know, what is one word to describe how you are feeling today in the midst of this pandemic? We'll post in the chat box, you're going to see a link to where you can register your one word, and we'll post this, pin this on the Facebook. And we'll come back with a few other polls, and near the end of the event, we'll give you the results. And now it's time to meet our panelists, and I hope that they're following the regulations in the state of Maryland. Hello, hello, hello. Look at us. You see, I have my mask on and my hat. And we need to be role models for the country, for the state. And this is what time it is. And it's kind of a reminder that this is a very unusual time. So thank you very much for role modeling what we all should be doing. And I'll ask that you, if you're in a safe place, you're not around anyone, you're more than 6 feet away, you can take your mask down. And I'm curious, Mr. Mayor, not only what your one word is, but before we do that, let's find out what the word is from the Dean of the School of Public Health. Dr. Lushniak?
Yes, thank you so much, Stephen. And my word is frustrated. Really, it almost hits to the core. So on behalf of the School of Public Health, I just want to welcome everybody to this important event. Notice that it's people who have incredible responsibilities. We have mayors, we have delegates, we have senators, we have doctors gathered here tonight, right? But most importantly is the theme that we're talking about, something that I'm frustrated over amongst many other things in the midst of this pandemic. And that's the idea that we have incredible disparities going on in our nation, in our state, in our county, and we have to do something about it. And so therefore, welcome to this very serious and important discussion. Thank you, Stephen.
Thank you very much, Dean Lushniak. Omar Neal, former mayor of Tuskegee, Alabama, and host of the radio show, You Got the Power. We're so glad you brought the power right here to us here in the state of Maryland. How you doing, Mayor?
How you doing today, my brother?
Oh, you see, I'm ready to go. Fired up.
I see you're ready to go. Let me tell you what my word is. It's hopeful. You know, in the midst of this pandemic, this crisis of epic proportion, I'm hopeful. It was Dr. King that says we're bound up in a mutual garment of destiny. And so therefore, what affects one affects the other. And I think that this pandemic has brought that home to us in ways that no other experience has, that we're interrelated and interdependent. So I believe that through this disequilibrium, growth will happen, human growth, human empathy, human connectivity will grow out of this experience. And so I'm hopeful that if we learn from what we're going through, then we can make a more perfect union.
Well, I think that we're at an inflection point, and the COVID-19 pandemic has really exposed some deferred maintenance on our public health and systems and causing all of us to reevaluate some of our core values. Let's find out what what our guests' words were and what they begin this conversation, Mr. Mayor.
All right, let's just go through. Deidre, let's start with you, and let's talk about what your word is and why you have come up with that word during this time.
Yeah, so I would have to say I was going to borrow the same word as you, and I maybe for similar but for different reasons in some ways. And I am also hopeful. I think what makes me feel hopeful is that we're starting to see a focus on some of the real systemic issues that we know have existed in our society that have disadvantaged so many groups of people that we're going to be having a conversation about tonight. And I'm hopeful that this placing of a magnifying lens in some ways on this population by necessity, because it's so glaring right now that we will come out on the other side of it doing better for these populations in the end. So that gives me hope.
Thanks, Dr. Cruz. Senator Sitnor, what's your thoughts? What's the word and why does his word resonate with you at this time?
Yes, and good evening. I say the word has to be changed, and looking at change from a variety of ways. One, when you look at all the disparities that this disease has somewhat brought our attention to, we need to change how we go about dealing with these disparities across this state. In addition, when I think about change, I'm looking at how we're looking at the way that we're looking to use technologies in order to address the COVID crisis, and the idea that you have some of these countries outside the United States and even within the United States beginning to think about or consider the use of certain surveillance technologies in order to keep people healthy. And I'm one who is constantly concerned with how our government tends to push the boundaries when it comes to the Fourth Amendment. So looking at surveillance and trying to weigh the public health with our rights of privacy is certainly something of concern that I have. But change is bound to happen. And then, but in the words of the great Gamble and Huff, we're all in this thing together, so we got to work it out.
Delegate, Melnick.
Thank you. So the word that comes to mind is overwhelm. Truly, the amount of suffering that our community, especially our Black and Brown communities, are going through could have been preventable. It's truly shameful that it came to this, to a pandemic, for us to see the needs in our communities. And I'm telling you, we legislators, social workers, nonprofits, everyone is getting calls 24/7 about the needs in our community. So I'm hopeful that as we move forward, we don't need to study it. We know we have health disparities, but we need to find out the gaps. We need to get resources and really deal with it so this doesn't happen again.
All right, thanks so very much. Dr. Sandra Quinn, your word and why?
Well, the dean started with frustrated, and I would go to angry. And angry because there's suffering that is happening that's unnecessary, that we have known the fundamental causes for decades, and that we did not take some of the action that could have been taken, both to prevent getting here and also to mitigate it even when we began to see it initially. I will add a second word, hopeful, with Mayor Neal, that we are now turning our attention and a spotlight, and that may we never be here again because of the changes we make now.
Thanks so much, Dr. Quinn. Dr. Breathwaite, what's your word and why?
My word is optimistic because when you look at figures like Serafina and you look at Tubman, I have coined the word solutionist that I've been able to pass on to some of my mortal leaders, that in spite of the past and the present, if we have an optimistic perspective, we know that things are going to change. And we as leaders have to generate that kind of energy and that kind of passion for change. So optimism has been guiding me in terms of dealing with the present, because we know that there's going to be a better future, and we have to be able to help guide the better future.
All right, thank you very much. Senator Lamb, you're next.
Thank you, Mayor. It's a pleasure to be here, and thank you for organizing this. I think my word, when I think about all that we've come through and yet more to come, is together. That when you look in recent modern history, there's never been an event like this that has brought the entire world together in a shared experience like this. And it's really that sense of togetherness that is important for all of our and each of our safety, that we're all in this together, that our safety from a public health standpoint depends on each other. And our ability to get through this pandemic is also a shared experience working together, whether it's scientists working together on a vaccine or policymakers coming together with sound policies that will help our communities build and come back up and build herd immunity, all shared experiences that we need to continue to build on together in order for our communities to come out of this pandemic. So I think together is an important word because it's something that really shows that this has really shown that we are a united community across the world together in this shared experience, and we will continue to work together to come out of this.
That's good. Thank you very much, Senator. Delegate Asario, what's your thought? What's the word and why doing this time?
So, well, first, thank you to the organizers of this really important discussion. I would say that I just take words from some of my fellow panelists and just say it's a mix of frustration, anger, and hope, and hope, really. Frustration that we are, as a country, we are capable of putting a man on the moon, but we are incapable of building a healthcare system that ensures that we are taking care of everyone that lives in this country, and especially those that are marginalized and vulnerable. Angry at a system that produces the kind of health disparities that we see amongst communities of color, Black, Brown, Indigenous, undocumented, and knowing that it is the result of structural racism, and hopeful because I know that I work with some really good people. And as an organizer, I know a lot of good organizers and activists that are working in this space. And I'm hopeful that we would not only as a people be able to organize around these important issues that relate to public health, but we will see the kind of changes that we're demanding in the streets to ensure that we're building a healthcare system that provides everyone with quality healthcare and everyone is covered.
Let me go back up to
Mr.
Dr.
Mayor,
Thomas.
yeah, can I have a word?
Yeah, give me your word now.
You know what my word is?
What is it?
Humility. Humility. I think this has humbled us to the limits of what we can control, and that nature can humble us. And I'm humbled by the healthcare professionals who are out there on the front lines. We have two physicians on the panel here tonight. The picture behind me is my mother, who's a nurse. If she was here, she'd be on the front lines. I think we need to really think about the frontline healthcare workers, the grocery store workers, the loading dock, the folks who are now in the meat packing plants. They are on the front lines to keep our quality of life going during this pandemic. Let's give thoughts to them and their sacrifice.
Yeah, I want to move to a space. I want to bring back up Dr. Quinn. Dr. Quinn, you mentioned something to the fact of anger and that deals with the fact that we knew about health disparities. We've always known about them, and we knew that these people were most vulnerable, and that in the event of something as widespread and atrocious as a pandemic, these people would find themselves on the short end. We knew that. Talk a little bit about, because everyone does not know what health disparity mean. Can you kind of encapsulate it and put it in layman's terms where people understand what you mean and why you're frustrated about that?
Thank you, Mary Neal. I mean, I could spend a lot of time, as I know the whole panel could, on talking about this. But what I mean, health disparities are not simply a difference. They are caused by underlying social determinants of health: racism, poverty, marginalization, immigration status. They are caused by a number of factors that put people at distinct disadvantage, and it plays out in living in neighborhoods with exposure to toxic substances, with food deserts, with inadequate healthcare, with inadequate health insurance, with poor public investment in education. All those things help to put people at risk in a couple of very specific ways in this pandemic. Number one is, if you've been one of those people that did not have the advantage of the education that all of us have had, then you are likely to be that worker who doesn't have sick leave, whose job can only be done in the workplace, you know, be it the landscaper, the janitor, the person going out actually and buying the groceries for the rest of us right now, or picking them up for us and delivering them. The people who don't have a choice, the restaurant workers, many undocumented, the meat packers, you know, who are Black and brown and often undocumented, who can't stay home and work like we can. So then we have a burden of existing chronic disease that is born out of all those conditions, those social determinants that put people at risk once exposed and infected to severe disease. And then finally, We know from previous pandemics and my own research in 2009, 2010, that especially Spanish-speaking Latinos had increased risk from exposure and also the lack of access to care. So what does all that mean? It creates a perfect storm. And we're in the midst of that perfect storm, but it's not as if we didn't know it was possible. I learned it certainly in 2009, but we've known some of these things about pandemics in our history. We just haven't acted.
Dr. Braithwaite, you look at this from a panoramic view daily. You are looking at health disparities. You're looking at how healthcare is provided to different groups, and you see the disparity in primary care for certain groups and other groups that don't have insurance, and their entree into the healthcare profession or the healthcare industry is through the emergency room. We've seen this for years. What is the question that you asked yourself when we have this kind of thing persist? As Dr. Quinn said, why does it persist when we know better?
Why does it persist? What has history to tell us about its persistence? Now, if we go back into record, we know that what is happening today is not new, because since 1895, we have had some indication of disparities. As a matter of fact, Booker T. Washington, he mentioned at Atlanta Exposition, and he discussed the deficiencies in Negro healthcare. And that's the phrase he used, Negro healthcare. And that was in 1895. And if you go through history, you would also find up to 2002, the same thing, when we have the Institute of Medicine report confronting racial and ethnic disparities in healthcare. So the question to my mind is, what is happening today has roots in history? And if there were no lessons learned since 1895, in terms of primary care, in terms of hospital care, and we know the disparity in hospital care that was somehow righted by Johnson administration when he put Medicare into law. And the thing for me is that persistent disparities can be looked at from three perspectives. We can look and say that the government should do something. And we are right, the government should do something about these persistent disparities. And secondly, community has a burden to bear, and what the community leaders, churches, academics can do to help right these persistent disparities. But I think I come to a third also conclusion. And when I ask the question, are some of these disparities preventable? Now, if we say that some of these disparities are preventable, the burden is not just on government to do something about them. We replace structural racism with fairness and justice. Not only agitation and advocacy from the community leaders, but if we believe solely that disparities that are preventable have a role in persons' behavior, then we ask the question, to what extent can we motivate even individuals who are in poverty to take care of their health? Is there a personal responsibility factor? Is there a personal responsibility side of this discussion? So yes, I think that as we daily deal with the issue of persistent and ask governments to do something, and ask our community leaders to do something, we also should ask our population to do something. And I think that triad, that triangle of responsibilities would help us get rid of the persistent, even though we have the social determinants of health and we have the healthcare system, I think individual responsibility should also be called out.
You know, I want Dr. Cruz to come and help me here. It's what we experience in this congenital, or is it socially derivative? And if so, to what extent is both influencing health disparities?
Yeah, thanks for that question. So I think this is a really common question that those of us who, as researchers who study disparities in health, it is incredibly rare to find a health condition that where we see disparities that is actually due to a genetic factor. That's what you mean by congenital. In fact, most of the disparities that we're talking about tonight really have their origins in social structures. And so just to really, touch on something that Dr. Braithwaite just said, when we think about the role that individuals might be able to play in terms of, helping us to reduce these disparities that we see, I'm a firm believer that there is still a great responsibility that lies with those structures, particularly those power structures, to actually arm those who are disadvantaged with what they would need, the tools that they would need to be able to live healthy lives. And so when we think about things, when we think about structures, we've talked already tonight a bit about the healthcare system, which makes it quite difficult for people who, for a variety of reasons, whether it's because they're a person of color or they have a low income, there are a number of barriers to not just getting some healthcare, but also to getting high quality healthcare. We're seeing this play out with COVID-19, where people are seeking to get tested and are being turned away because maybe they don't have exactly the symptoms that are being touted as the key symptoms. And there's some suggestion that certain groups are disproportionately sort of being turned away there. There are issues in terms of bias in the healthcare system as well that play a role. And then when you think about other structures, I do some work around understanding our food system and how access to healthy foods plays a role in some of these disparities that we see that we're finding out that are risk factors for COVID-19, severe illness from COVID-19, including things like hypertension and obesity and diabetes. And we know that that our food system is an unjust system. We think about where healthy foods are positioned and how unhealthy foods are marketed to socially disadvantaged groups. And so I think the onus is still on those power structures to facilitate, if you will, individuals making these healthy lifestyle changes that I think all of us would like to see everyone make.
Senator Lamb, thank you very much, Dr. Cruz. Senator Lamb, you wear two hats. You are a physician as well as a senator. So I'm going to ask you to put on your doctor's hat for a second, and then I'll bring you back to your senator's role. It would appear that if there are vulnerable populations that are more susceptible to COVID-19, the virus, then the testing would be concentrated in that area to determine the extent by which it exists, particularly because the death rate or mobility of those people are higher. Why don't you think we have focused and concentrated our efforts in those areas where they had the highest vulnerabilities?
Right. Well, thank you for that question. I think it does bring up a very important point that we ought to be concentrating our efforts, particularly when it comes to testing in some of our most vulnerable communities. We see some of the highest rates of spread of COVID in those types of communities. And if the resources aren't there to test them, we're really missing a lot of important data and being able to concentrate resources to help those people that are in need. An example here in Maryland is that the state health department recognized that we had another vulnerable community, which was the elderly community, those who are older and in nursing homes. And just the other day, the state stepped up and said that they would be testing everyone in these nursing homes. Well, and that's important and that's great because we've seen a lot of outbreaks occur in those environments. But there are a lot of other vulnerable communities that are out there as well, different ethnic and racial minority groups, the homeless population, those who are incarcerated. All these are vulnerable populations that also need resources, and they're particularly vulnerable during this time. If anything, a pandemic really shines a light and highlights and exacerbates the plight of those that are in these vulnerable communities. And that's why it's really important to be able to focus those resources.
Let me go to, thanks so very much, Dr. Lamb. Let me, Senator Dr. Lamb, let me go to Jocelyn Pina Melnick. Let me ask this. We talked earlier about your frustration in the lack of concentrated, asserted effort on the part of government, quote unquote, legislators to really address the issue in a systemic way, not cursory, but more robust to create critical mass. Talk a little bit about why you feel there hesitation or resistance on the part of governments, not just in Maryland, but nationally, to really delve into the issue of disparity and to make sure that resources are placed where they're at the greatest need.
There's a saying that says that the money should follow the policy, not the policy should follow the money. So oftentimes when we're legislating, we get what is called a fiscal note, which is the impact of that policy on the budget. And a lot of these policies are big ticket items. So oftentimes, I'm going to be very, very frank, that fiscal note comes in front of our committee, many of our committees, every committee, and it's very expensive. So there's that hesitation because it's so expensive, but you either pay now or you pay later. What we're learning from this pandemic is that it's worth the investment. It is worth investing in these communities. As you look at the zip codes, they have the highest number of people that are COVID-19 positive. For example, you have Langley Park in Prince George's County, which is the immigrant Latino community, where many of them live in an apartment, 9, 10 family members, where if one of them is positive, they can't get away from that family member. They don't have a place to go. We have, a lot of them do not have Medicaid. And oftentimes, depending on who is in office, you don't want to, a lot of times when you're advocating, for example, for an undocumented person to be covered, they don't qualify for Medicaid. Therefore, during a pandemic, they can't go to a primary doctor. They have to call the health officer. There are all these obstacles in the way for them. As we legislate and we move forward, we have to seriously consider covering everyone, regardless, because the state will save a lot of money. So I know that oftentimes for an immigrant, sometimes you can apply for emergency Medicaid, but that is not always the case. So as a state, we have to create a fund to make sure that undocumented people are covered. We have to make sure we continue to screen people for Medicaid, which we've done a good job because we're one of the states that expanded Medicaid with Obamacare. And we have to make sure that we have primary care and that they follow that person that has been tested positive for COVID-19 and look at the underlying condition. Almost everyone has a pre-existing condition in our community, and a lot of people Black and brown. So we have to have wraparound services where you have primary care doctors and you have social services also in the same building so that it's systemic and you can have a greater impact.
Can I add something to what Delegate Pena-Melnick was saying too? That I think she brings up a very important point about the fiscal note. And as a public health physician and practitioner, the fiscal note is really challenging, whether it's on the state level or on the federal level in Congress too, that when legislators and policymakers are oftentimes looking at how much a public health program might cost or how a preparedness office budget is. And those are all important pieces that need to be funded to prevent the next pandemic, to prevent an outbreak, to prevent chronic disease that might happen, prevent infectious diseases that might happen. And the challenge for us as lawmakers is that looks like an expense all the time. It undervalues the power of prevention in a pandemic that doesn't occur, or folks that are able to stay healthy. That's never accounted for in those types of fiscal analysis or fiscal notes here in the General Assembly. It's been a pet peeve of mine. It's a real challenge. And I think that's where, if there are public health folks and students that are watching this, your advocacy is incredibly important to be able to push forward with funding for these programs. Because oftentimes they're the ones that are first on the chopping block. And that's why we see local health departments' budgets shrink and state health departments' budgets shrink, because folks may not realize that the prevention is really important to be able to fund on the front end, and you'll reap dividends later on the back end in lives saved and people helped.
Senator, thanks so much, Senator Lamb. Senator Sidnor, when we were just talking about practical solutions, I mean, literally dealing with systemic issues, not dealing with surface issues, and coming up with practical solutions, legislation that has long-term impact on vulnerable communities. When you look at that, are you all looking at the mental health of people? Do you look at transportation? Do you look at the lack of health care? Do you look at all of those issues that give rise to these social disparities?
I think you have to look at all of the above. You have to look at the way that our transportation systems are set up. I mean, here, when the crisis first happened, one of the first things that we saw in the Baltimore metropolitan area was there was a decrease in the number of buses that were then being put out into service. You had people who then could not get to their jobs who were dependent upon that type of public transportation. With the social distancing, it's extremely difficult to get on a bus and socially distance. As was mentioned by some of the panelists earlier, number of Black and brown people, they are those frontline workers in the MTA in transportation. I know there was a story that went nationwide of the bus driver in Chicago who ends up passing away because of being exposed to the virus. So I mean, you look at transportation, mental health. You have to look at that as well. We get so many emails that have been coming into my office with parents, fathers, mothers, who've been dealing with all kinds of extremely stressful situations, whether it be them being furloughed, losing a job, or even dealing with loved ones who are dealing with COVID. And so, I mean, there's an extreme amount of stress that's going on, and that stress, you can feel it coming through the emails and the phone calls that we're getting. And I mean, it's extremely frustrating when you're there and you're trying to help, and you're running into some of the issues that we have run into, and you just do your best to try to make certain that those people know that if they're reaching out to you, you're going to be the best advocate that you can be to try to get them the help that they need, whether it be getting their unemployment issues resolved, or even at sometimes when people are just looking for a meal for their children.
Yeah. Thanks, Senator Sidnor. Delegate Acevedo, let me ask this question. We talk about, poor people as if they are disposable oftentimes, or that they are less valuable. We talk about people in the terms of everybody can do this because I can do it. We talk about social distancing as everyone has an independent dwelling that's away from everybody else, and that they have multiple rooms in their homes that they can isolate themselves and quarantine themselves from other family members. There are people who are in this country, and particularly, let's go into Maryland, that cannot engage in social distancing in a practical way because of their condition. Do we talk to them and create ways by which we can help them to mitigate the contraction of the virus through addressing those critical issues?
Yes, we absolutely do. I think what this pandemic is also showing is just how vulnerable our middle class is. We are looking at a crisis, and as of today, about 30 million Americans have applied for unemployment insurance, right? When we are looking at data where 40% of Americans cannot afford a $500 or more unexpected bill. And if we were to bring this home here to Maryland, right, Delegate Pena-Melnick is absolutely right. The money should certainly follow the policy. And we should also ensure that money is being invested in the areas of healthcare that we know disparities exist. So for instance, while we are one of the wealthiest states in the union, we spend roughly a third of our state's budget on healthcare, so about $15 billion. And despite these billions of dollars that we spend, over 400,000 Marylanders are not insured, right? So when we think about a pandemic and we think about testing and we think about treatment and we think about those who are vulnerable, we have to look at one, the economic security of Americans and Marylanders, but we also need to look at the amount of Americans and Marylanders who have health insurance. And what's clear is that there are hundreds of thousands of people in our state, despite us spending a third of our budget on healthcare, who do not have health insurance, right? And these are people that are going to face this pandemic by themselves, right? Because you either cannot afford health insurance, right? Or any treatment that you receive, you won't be able to be able to pay that bill at the end of the day. And that's the reality of a lot of Marylanders. We have to address the public health issue, but also the economic insecurity issue of this pandemic. But I also want to go back to what you mentioned earlier about disposability. I know Dr. Brathwaite talked a little bit about just the historic racism around healthcare and the disparities amongst communities of color. And I want to talk about something that oftentimes we don't talk about, which is disposability. You talked about that and the disposability of certain communities, Black, Brown, Indigenous, undocumented. We see the crisis at the border right now. There has always been this politics of disposability in the history of the United States, and we see how that plays out in healthcare crises. And so therefore, Black, Brown, Indigenous, undocumented people are oftentimes seen as disposable. So that's why when we see things like a pandemic disproportionately impacting communities like ours, you don't see the sense of urgency and you don't see the kind of care that we put towards other issues that impact other communities, right? And so that is something that we need to talk about. It's the politics of disposability. Yes, we can talk about structural racism. Yes, we can talk about health inequities. Yes, we can talk about the disinvestment in our healthcare systems, but we must first and foremost deal with this issue of the politics of disposability that has permeated our government since its inception. And that plays out in many ways. You know, Dr. Brathwaite can recall this. The Maryland Department of Health came before my committee, the Appropriations Committee, to provide an update on a number of things, one of which was our state's response to the opioid crisis, right? And if we look at our state's response to the opioid crisis versus, and I wouldn't just say our state's response, but really our government response to the opioid crisis compared to other crises that impact other communities, you would see the difference in the way that we care about issues and the way we respond to them, right? And so we have to deal with a number of things, from the politics of disposability to the lack of commitment to policies that would eliminate these disparities that we're talking about, such as Medicare for All. We have to deal with the economic insecurity issue. People can't survive pandemics if they're economically insecure. This is not just about people's health, it's about their economic security as well. because folks are homeless because, again, you know, I don't have the means, the financial means as other people to be able to socially distance, to be able to quarantine or to do what other people of you know, much more means are able to do. So there are a lot of layers.
What I want to do is this. I'm glad that you want to do that. I want to bring the panel into this conversation.
And yeah, one thing we know is that you can't move forward looking through the rear view mirror. Now, we've just given our audience the context for why these underlying conditions exist, and now they're exacerbated in the pandemic. The pandemic is showing us our shortfalls. One day we're going to have a vaccine. We're talking in public health about herd immunity. I don't know if the people know what that means. I got my cowboy hat on. They may think it's about rustling cattle. But if I could just take a moment, Mr. Mayor, and throw a ball to the dean, what is herd immunity? What confidence should we have with the new therapeutics coming on? And how might that help us move forward in a way to close these gaps in the disparities that you've just heard our panelists talk about?
Well, thanks, Stephen. I think, you know, the concept of herd immunity really comes up in two sort of realms. One is in the vaccine realm, right? We talk about the idea if we have a vaccine available, let's say we have a vaccine against measles, as we do, that at a certain point, if we vaccinate enough people out there, you know, and usually the numbers are, we want to get to 89 to 90% without a doubt. And ideally, we get to 90 to 95% of the population vaccinated, protected, to really protect society, right? To protect the herd. People don't like that term because it sounds so animalistic, but you know, the reality is we are part of a group. Like it or not, that's the term that we've been inherited with, but it's group immunity, right? It's population immunity. Now, when we talk about it in light of COVID-19, what do we talk about? We talk about the idea that, you know, at some point, we hope we have a vaccine. The other way of getting there, which is something that the British looked at initially, and maybe the Swedes are playing with this a little bit, which is if enough people get infected, we'll protect everybody because we'll get to that 70, 80%. But what does that acknowledge? That acknowledges to get there, a lot of people are going to suffer and a lot of people are going to die. So it's not necessarily the right approach. Regarding the vaccine scenario, you know, we keep saying 12 to 18 months. We've had some great information that came out of Oxford a few days ago of talking about a breakthrough. But I am always, you know, very leery of these breakthroughs, right? I mean, show me the money in essence, right? And the money really has to be the progress of what is in the vaccine. Is it safe? And will it in fact protect the population? And then when we get to what the disparities issue is, how are we ever in a short time period going to be able to get a brand new vaccine to everybody who needs it? And that becomes a disparity issue, not only within the United States, within our own communities, but becomes a global health issue, right? Mm-hmm. Which is, what are we sending to Africa? What are we sending to Asia? Who developed the vaccine? Who owns the vaccine? Who's paying for the vaccine? So a lot of these issues come up, you know, when we talk about immunity and potential progress. I keep telling, right, everyone, we talked with our students about this. We in public health, we have to be optimists, right? If we're pessimists, we wash out early in our careers. And the optimist in me is we will find a pathway. But the reality is we have to do it right so that we don't end up digging ourselves a deeper hole in the disparity realm when we start having both therapeutics and we start having potential preventive measures out there.
So Mr. Mayor, I would ask you, if a vaccine was available tomorrow, Mr. Mayor, and to all our panelists, would you take the COVID-19 vaccine? Are you likely to take it? Are you unsure? Or are you unlikely that you would take the vaccine? And Mr. Mayor, let's come back to the panel and open this up, because the very issues that were raised play out once there's a solution. Either right. Institutionally, they don't have access, or because of fear and mistrust, they are afraid to take the vaccine. These are all factors that we can make a difference in right now.
Well, trust is a calculated risk. And when you have experiences with institutions that have not been fair and equitable with you, it's very difficult to accept on face value what they say is in your best interest. And so I would go in the middle and it being unsure. I think that the dean was correct. When we hasten to bring out vaccines, oftentimes we miss those critical steps, particularly as it relates to clinical trials that speak to people who look like me, right? And so therefore, if we are not a part of a clinical trial, I don't know if I want to use the vaccine that comes out of a trial that does not take me into consideration. And that's where unsure would come from my perspective.
I want the speakers to unmute your mics so that we can have a conversation as the mayor takes us through this next phase. You were about to throw the ball to Dr. Quinn. You had a question for her?
Yeah, Dr. Quinn, you know, this is what's confusing me. We've been talking about health disparities, and we used basically as a predicate economic disparities. But in the state of Maryland, one of the more affluent counties in your state has the highest level of virus contraction. So my point
Prince
is, Prince George County, right?
Yep.
I mean, so that's a contradiction. Why is that as you looked at it?
I think that's a complex answer, and I'm sure Delegate Pena-Mellick would like to comment on it as well. It's not just socioeconomic, it's racial and racism. We're the highest income African-American county in the nation. We also spend $38 and some cents per capita investing in health and human services in Prince George's County. $38 and some cents. It's around our neighbors in Montgomery County spend $224 and some cents on investment in public health. So, you know, I think there are a lot of things here. We have a burden of chronic disease. We have some parts of our population that can't social distance for all the reasons we've just discussed. So they are out there being exposed. And then we actually have a health department that's working incredibly hard, but they're fighting an uphill battle because they do not have the resources that they could use right now. So I think there are a whole array of factors to why Prince George's County has been hit so hard.
You know, maybe Delegate, maybe you can help us out with this. You were mentioned in Dr. Quinn's answer or response. What's your take on it?
Absolutely. Yeah. I mean, I agree with her. In addition, you have a very large number of people in Prince George's County that are uninsured. And that is really makes it very difficult for a person who's uninsured to have access to health care. So while you have zip codes that are doing better than others, you have some zip codes like, Langley Park, that is a lot of immigrants that do not have health insurance because they don't have access to the government programs. So Prince George's County is a beautiful county. It is so diverse. It's like we call it gorgeous Prince George's, but it also has its challenges. We have about 45% of our students in the school system that are children that are from other countries, right? Hispanic. You have a lot of schools that are 70%, immigrant. You have people from all over the world, not just Latino, from Africa, you name it. And they do not have access to the programs like some of us that are insured. So we need to make sure that people aren't insured, that they have access to it. We need to make sure that they have housing. Okay, that's an issue. It's not just the healthcare. It is also having access to housing. I mean, we need to make sure that they have good jobs, they pay well. not just a minimum wage, but a living wage for people to be able to make it. We have to make sure that they have transportation. A lot of the people that live in the zip codes that we just discussed do not have transportation either. There's a lot of needs in these communities, and we need to seriously consider looking at all our zip codes, looking at who lives in there, and investing more resources into them, having more wraparound services, making sure that everything is in Spanish, in English, and other languages that people can understand. This is really going to change the way we do business. It really will.
And Mr. Manera, if the audience may have thought we'd be talking about the code of the virus and the biology of the virus, and look at this conversation. It's about all the conditions that make the virus more virulent in terms of its outcome on us. And I'm so glad to hear the legislators recognize that these other issues are indeed important factors in a health arena. Sounds to me like it's like health in all policies, from transportation to job readiness to bridges. There are health implications, and we have legislators here today who recognize that.
Even said about the review, but let's look forward and ask the question: are there things that are currently being done in spite of the overwhelming disparities that can be highlighted? I would let Delegate Pennant know that the Office of Minority Health has a program in Langley Park. It has been called Embrace. And this program is enrolling individuals from certain zip codes in Langley Park to insurance, health insurance. And we have been doing that for the past 4 years. How widespread it is may not be the answer right now, because we also need some more resources. But certainly we recognize the uninsurance situation in Langley Park, and we have a program directed to do that. And this is across other entities. We have at least 15 motor programs in 12 other jurisdictions. And these are intended to look at zip codes of vulnerability. And I think that, as the Dean said, optimism rules in public health. And if we can spend a couple of minutes, I ask the question, to what extent can we, over the next, even though we have the pandemic, is there something that we can do over the next 60 days during the height of the pandemic to address disparities?
Yeah.
And I think that that would help adjust the radar somewhat and recognize that there are glimpses of hope, even in certain zip codes that are very, very vulnerable populations. And sometimes, possibly over the next 60 days, we might be able to do something to reduce the disparities.
The last thing I want to do, and I want this to be a round table, and your last word, I want everybody to take this question. It was Dr. King in his last admonishment to us in his last book entitled, Where Do We Go From Here, Chaos or Community? I want to ask, and I'll start with you, Dean, what if we could kind of look into a crystal ball, what measures should we be taking now to bring about those desirable outcomes in the future, not only to deal with this pandemic, but to address health disparities and to prepare us for whatever may be in the future? Right now, what can we do?
And I will be brief. What we have to do is we have to stop doing the same damn thing that we've been doing after each and every crisis that we've had, right? Which is we throw money at it, we all sit around and talk at it briefly, and then we forget, right? God help us if we forget about this one. And in essence, because this ties in with not just a public health crisis, but also a severe economic crisis, I'll be honest with you, Mayor, what usually happens with economic crises is, right, the underrepresented minorities community suffered disproportionately to the rest of society in economic crises. And guess who else suffers disproportionately? Public health, right? Suffers, right? That's the first thing to be cut. Let us remember that we're in a very unique situation. This is the optimism. We have a severe economic crisis that came about because of a public health crisis. Let's not forget that. And in the middle of this are the underrepresented communities that are disproportionately suffering. So we can't forget, and I'm so glad that this was brought up by several of the delegates and senators. You know, we're going to be throwing money at this problem. Let's throw money in the right direction, and let's keep it consistent so we never end up here again.
So, Mr. Mayor, just before you go around, let's throw just a few of the questions out that we have from the audience. We don't have to answer them all directly, but it might flavor how they do their closing comments. So we'll have Dana Ackerman, who's been curating the questions in the chat box. Dana, if you could, you're on now. We're just going to have you just read off several of the questions that you've curated and allow as the speakers begin their closing remarks, they'll be able to speak to them. Dana is one of our outstanding young students here, graduate students here in the School of Public Health. Okay, what do you have, Dana?
So one of the questions I have is, how can we inspire anti-racist action and policies?
Okay, keep going. We're just going to read several.
All right, another is, how can we get more minorities engaged and involved in clinical trials? The third is, how can we get businesses to invest in public health, since good public health keeps businesses most productive? And one of the last questions we have here is, so what do solutions look like? What can we do now for vulnerable communities of color?
Thank you, Dana. So keep that in mind as you begin to make your closing remarks. Go ahead, Mr. Mayor. Who's next?
Okay. All right. Let's just go around. I want to go with Delegate Gabe. Let's go with you and let's see what if you were to capsulate, if you were to give your last message to our listening audience, what would it be?
So it isn't an accident or coincidence that communities of color, Black and brown people, are being disproportionately impacted by this pandemic. It is the result of policy. It is the result of policy changes. And that is what is that is what is needed in order to deal with the kind of disparities and racism that we see within our healthcare system. I know one of the questions was about how do we deal with racism or how do we have an anti-racist approach in healthcare? Dr. Brathwaite, to call on my West Indian brother again, he recalls the Appropriations Committee hearing that we had with the Maryland Department of State. And one of the points that I raised was, why is it as a state, Maryland is not following other jurisdictions that have declared racism as a public health crisis, right? We can train healthcare providers on implicit bias, et cetera. But this is about looking at racism as a public health crisis, right? And once we look at racism as a public health crisis, then we deploy resources differently. Our posture towards the issue is differently. The policies that we craft and we pass will be different. And so that is how, that is what I'd say is the first step, is declaring racism a public health crisis. And I think that's something that we should be striving for as a state. I know some localities are pushing for that. But in terms of this crisis and how do we help communities of color going forward, there's a number of things that we have to do. And I'll leave folks with three things, right? One is the policy, which is we need Medicare for all legislation, whether at the federal level or at the state level. Maryland is unique in that we are the only state in the union that if we wanted to, we could pass a single payer Medicare for all system tomorrow, right? We're already spending $15 billion, a third of our budget on healthcare, and we're still seeing the kind of disparities that we're seeing. We're still seeing 400,000 Marylanders still uninsured, right? But we have the opportunity to pass that. I've introduced legislation, the Healthy Maryland Act. Senator Joe Carter is my sponsor in the Senate. And we're hoping to get some traction on that legislation because in the wealthiest state in the union, Maryland being the only state that can actually move forward on Medicare for all. And when we see the dragging of the feet at the federal level, we have to take leadership at the state level to ensure that we're providing health coverage, but we're also eliminating those disparities. I mentioned racism as a public health crisis, but also lastly, it's about dealing with structural racism within our economy that keeps Black and Brown, Indigenous, and undocumented people poorer, and as a result, sicker, because we know poverty is very much tied to the kind of poor health that we see in communities. And when we talk about poverty, we know that communities of color, we tend to belong to low-income households. We tend to be taken advantage of by this capitalist economy. And we have to acknowledge all those three things. So those are the three things I would say that at the state level, as a state, we can do to ensure that we are better prepared for a pandemic or a health crisis of this magnitude in the future. One is Medicare for All legislation. Folks, please check out the Healthy Maryland Act. This is a bill that is actively going through the Maryland General Assembly. It's assigned to the Health and Government Operations Committee, of which Delegate Pena-Melnick is the vice chair. 2, racism as a public health crisis. It is. We cannot implicit bias train our way out of the structural racism within our healthcare system. It's just not going to happen, right? There has always been a politics of disposability of our lives, and that has to end. And then lastly, the structural racism in our economy that keeps Black and Brown people poor, and as a result, sicker.
Now, Mr. Mayor,
Yes.
as you can see, the legislators and scientists here in Maryland are a source of hope. They are
Right.
on top of this. And
Right.
just to flavor this one more time, this is what the people are saying in the audience when we ask for their one word. As you can see, we won't go into it. We'll have these on the rebroadcast, but overwhelmed, stress. And so we need to also help people do self-care. What's the next poll result? Help people do self-care, including our healthcare workers. Who would take the vaccine if it were available tomorrow? 40% are likely, 36% unsure, 24% unlikely. And you heard what the dean said, we need 70 to 90% coverage to get to herd immunity. So these are things that we can do right now to address the concerns that people may have that make them unsure or unlikely. Now let's come back to the main audience and keep going, Mr. Mayor, as people make their closing comments.
Yeah, let's go to Senator Lamb. Senator Lamb, you are now given the opportunity to share your last thoughts with the audience.
Yeah, thank you. And thank you again for hosting this. It's a really important discussion to have, particularly when it comes to these disparities that are affecting our communities. I think if anything, this really highlights to the public the importance of recognizing the social determinants of health. I think many of us on this panel, and then perhaps many in the audience, understand that health is interrelated with so many different aspects of our community, whether that's education, whether that's the environment and climate change, whether that's transportation, and so many other parts of our economy. And everything is interconnected. And yet oftentimes, other policymakers might look at things in silos, or members of the public might look at it in silos as well. If this has proved anything, it's shown that, our economy and our healthcare system is intricately intertwined, and the health of one is related to the health of the other. And so I think we need to think in those terms moving forward, and recognizing that we need to reinvest in whether it's education, transportation, the environment, to address issues like climate change, because they all affect our health. And so that's incredibly important as a message to take forward. And it's incredibly important for the audience and the public to learn from this as well, that we as a community need to address all of these issues together. And it's not just a siloed healthcare issue or a siloed environmental issue. All of this is a complex interplay in those social determinants, and all of you can serve as a role model in stepping up to advocate for these important issues.
Dr. Quinn, you're next. I started where you were. You got the power.
Yeah, you got the power, Sandra.
All right, there you go, Dr. Quinn.
There's my magic wand, right? Okay, so I think all of our minds are also on, what can we do today? And what do we need to do in the coming months? And so I think number one, in Maryland and across the nation, Governors and mayors are convening groups to plan for reopening and one day recovery. And the question is, are all the communities we've been talking about today, African Americans, Latinos, and Native Americans, represented in those planning groups? Are they there? Are civic leaders there? Are elected officials there that can speak to those needs? Number two, I think we really need to take a look at, as we do that, is it being informed by a health equity lens? And so that is really vital. As we reopen, are we looking very specifically for data that tells us that the disproportionate impact of reopening is again being felt by communities that already are suffering? And I think the third thing I would say that I believe is vitally important, I would look at vaccine disparities. I know that in a regular flu season, 41% of American adults get a flu vaccine. African Americans take it even less frequently for all the reasons we know, and suspicion and distrust, but also because providers don't make a recommendation and an offer. So it's not just people's attitudes. We got to start talking about the flu vaccine and COVID-19 vaccine, not in October, but now, in terms of working with communities to get them ready, let them hear their voices of their concerns, and make sure that they know exactly, and we're addressing those concerns, and that there's adequate supply of those vaccines, be it in Langley Park or be it in parts of Prince George's County that are disproportionately suffering.
All right, thank you so very much.
Dr.
Let's go to Dr. Cruz. You up next.
Sure. Well, thanks. First, thanks for including me in this discussion tonight. And I agree with all the final words that the others have offered. And so, but when I think about as a physician, when I think about kind of one thing that I would like to close on is just that I and others have a growing concern about the delays of care or seeking of care that we're seeing in this pandemic. And so when we think about what can be done in the short term, one thing that I would say is that for all of you that are tuned in tonight, and I know you have networks that you can sort of share this with, is certainly to try to encourage people to seek care if you are having symptoms of that could be of COVID-19. But one of the things we're seeing, and I know Dr. Lamb is seeing this as well, is we're actually seeing people not coming into care for other things, other health conditions. And many of us are concerned that when we look at the final numbers for these months, what we're actually going to see is that there was a spike in the death rate for the months of March and April and maybe May, but it won't all be from COVID. Some of it's going to be from people who died of conditions that we do have treatments for because they had concerns about seeking care in the setting of this pandemic. So that's one thing that I would offer as a physician. The other thing, and this is in response to one of the questions that was raised in the Facebook chat, and that is around minority participation in research. So as a researcher, I just want to comment on where I see the needs are in terms of that. I think in two places, we need greater inclusion with respect to who it gets to be involved as investigators in these sorts of studies, and that includes training future generations of researchers who come from diverse backgrounds, many of the groups that we have highlighted tonight in our discussion. But it also means that these studies that are going to be ongoing, these vaccine trials, that they include the voices of those individuals that really are most vulnerable, and that they're engaged in the whole process in terms of thinking about how are they going to reach out to these communities, how are they going to get people to enroll in these trials. I think that's really where we've lacked when it comes to thinking about minority participations. We haven't asked minorities to participate at the front end of the research development. And so those would be the things that I would offer. And thank you again for including me.
Thanks so much, Dr. Cruz. Delegate Pina Melnick, you up.
Thank you. And thank you so much, Dr. Thomas. And thank you so much for moderating and all the panelists. I really enjoyed the conversation. I want us to remember that reducing healthcare disparities requires all of us, right? The government, the policymakers, the researchers, the health professionals, community groups, the community health workers to work together. And we really need to do that because we can't do it by ourselves and we can't work in silo. We need to do more than access to healthcare. We need to invest in projects that address unemployment, incarceration, lack of educational opportunity, like it was discussed. We need to, look at how limited, access to healthy food in our Black and Brown communities are. We need to look at it in a holistic way. And we need to follow really carefully those that are COVID-19 positive. We need to look at the underlying conditions. We need to make sure they have a doctor. We need to make sure that we do put money into these policies, even if they are very costly, because at the end, most important, they save lives, but we will also save a lot of money. Thank you.
Thanks so much. Now, Senator Sitnor, you are up next, sir.
Sure. And again, I want to thank all of everyone on the panel as well, especially my colleagues from Latino Legislative Caucus, the Legislative Black Caucus, and the Asian American and Pacific Islander caucuses. We all wanted to be a part of this and make certain that everyone knows that we're all in this together as we're trying to deal with this pandemic. Now, what I believe is that we talk about being data driven, but we have to truly be data driven and not only collect the data, but we have to have the resources to analyze the data. And then once we analyze the data, we have to make certain that we're wrapping policy around that data. And as was said earlier, we need to make certain that we make our investments accordingly. One of the questions that was put forth was, what does a solution look like? And we've heard how COVID and this health crisis has affected so many things that look so unhealth related. This past session, after a number of years of effort from my colleagues and I and many alumni of our HBCUs, we finally were able to put together a legislative solution to end a 13-year-old lawsuit that looked at the disparities in treatment of our HBCUs. Now, why do I bring that up? Because there's research out there that shows that when you have Black health officials, Black folk tend to get more effective care and treatment. So the passage of that bill, which is before our governor currently, and we're hoping that he signs it, or if he doesn't sign it, he at least lets it go into law without his signature, but we really would like him to sign it. We're talking about money, resources that are going to go to support these schools as they produce our pre-med students. You're talking about Morgan's public health program, you're talking about Coppin and Bowie's nursing program and pharmacy program and others that they have over at University of Maryland Eastern Shore. We want to make certain that those schools have the resources, as well as College Park and your program. We got to make certain y'all have the resources to make certain that people are out there and helping with these solutions and making certain that these disparities are properly addressed.
Mr. Mayor,
again, I thank you.
Yeah.
Thank you so much.
Mr. Mayor, I was just going to say that as we kind of close out, there's one more poll. Just pull the poll up and we'll talk over top of it while they pull it up. We had a little different format here. Maybe people thought this was going to be like Crossfire. This was a very informative conversation. We just want you to, again, use one word. What did you like about this webinar? one word to just describe what you liked about the webinar. And as we close out, we'll put the word cloud up a little bit later, and when we post the recording, go ahead and pin that up to the top. One word, what did you like about this webinar? Now let's come back to everybody, Mr. Mayor. And I think that a lot of the conversations and issues raised, some of them are a show in and of themselves. The whole issue around the clinical trials, the issue around non-traditional solutions and people like barbers and stylists who could play a role in solving this problem. That's the show in and of itself. And I'm hoping that maybe we can do this again. Yeah, did we get everybody in their closing remarks?
Yeah, I think we did.
Lightning speed. Why don't you close this out before I do the thank you to our host and guests?
Thank you so much, Dr. Thomas. Let me first of all thank each and every one of the panelists. You all were incredible. I've done this for 29 years, and this is one of the most informative, insightful shows that I've ever done. I want you to know that. Thank you so much for your candor, for your clarity of thought, for your willingness to step out and tell your truth as you understand it. I believe that we all are possessors of some truth. And as we bring our truths together, then and only then do we get closer to the truth. Now, there's a saying that goes like this: once you know, then you owe. And so for those of us who have influence in areas that can be a remedy to the errors of disparity and all of the vulnerabilities that people who are disenfranchised and marginalized have, now is the time to not do lip service, but actually put your money where your mouth. Thank you so much for affording me the opportunity to be the moderator of such an auspicious program. Thank you.
And Mr. Mayor, again, you're down there in Tuskegee, Alabama, a tremendous history of civil rights there in Tuskegee. And so we're so glad that you're here. We hope you'll stay with us as we move forward. I want to do a special thanks and acknowledgement to our panelists, our School of Public Health, and we had a team of young scholars, students that helped make this possible, that worked with the legislators to make sure this, we've all been on the Zoom calls from Hades, right? I thought this went very smooth. Special thanks to the Asian Pacific Islander Caucus, the Maryland Legislature, Legislative Latino Caucus, the Legislative Black Caucus, the Maryland Department of Health, the NAACP of Maryland, our own School of Public Health, and all of the people who joined us on Facebook to kind of think about it, Mr. Mayor, liberate this technology in the interest of something positive. Let's do this again, okay?
Absolutely.
Let's do it.
Let's do this
Absolutely.
again. So here's what we want. Let's continue the conversation, ladies and gentlemen. And then I'm learning all my, binary terms. Let's do this again, family. How about that? Let's do this again, family. And we want you to go to this link here that you see on the screen. It'll be in the chat box, and you'll get a little survey that enables you to answer the question of how we can reach out to you for the next time. And then the last thing we'll put up, let's put up, if you have the results of the what you like about the session, we'll put that up, and we'll close out with the word cloud of what people liked about this particular format. Unmute your mics, everybody who's still on, unmute your mics. And here we go. Let's take a look at the poll results for the one word that characterizes. Okay, now the size of the word means that more people said that. It was informative. It was informative at a moment when we are filled with confusion. We have to do this again. You agree, Mr. Mayor?
Absolutely. It was absolutely informative. And we must do it again. I look forward to it.
Wish you all well, and tell everybody, put your mask on, be safe. Be safe out there. Bye-bye.
Bye-bye.
Bye.